everyone, my name is Sandi Htut. I'm a senior epidemiologist with the County of San Diego's Behavioral Health Services in the Population Health Unit. And today I'll be sharing substance use trends and insights that can help inform the health of the American Indian and Alaskan Native communities. And for the rest of the presentation, I'll be using the term AIAN when referring to this population. And before we get started, I'd like to take a moment to offer a land acknowledgement for the tribal communities whose lands that we are on today. We acknowledge that the San Diego region is made up of the traditional lands of the people, Kumeyaay, Lesueño, Coahuila, Copeño peoples, and we acknowledge the harmony that existed among the land, nature, and its original peoples who have since endured displacement, persecution, and systematic oppression. We pay our respect to the unceded territory and homelands of the 18 federally recognized tribes in our region. We honor the ancestral grounds and sovereignty of the tribal nations whose resilience, strength inspire forward movement towards more equitable and sustainable programs, policies, and practices. And for today's presentation, first I'll be going over kind of our data measures and our suppression information, a data overview of the national data, a local data overview, key takeaways, and then my contact information. So before we get into the findings, I just want to briefly go over some of the data measures that you'll see in this presentation. So counts are the simplest measure. They tell us the number of people, items, or events. Proportions show how a part compares to the whole, usually as a percentage or a fraction. Rates are a measure that show how common an event is in a population over time. And they compare the number of events to the size of the population, which makes it possible to compare across groups of different sizes. And for this analysis, we used crude rates, meaning the rates are not adjusted for age, and that was just the level of data available at the time. And to protect privacy, we suppress data when the numbers are very small, fewer than 11 people. And this isn't about leaving anyone out, it's simply just to make sure individuals can't be identified. And for AIAN data, we take extra steps, sometimes combining years or regions so that we can still share meaningful information while keeping privacy safe. And this next section will share findings from the 2023 National Survey on Drug Use and Health, focusing on AIAN people age 12 and older. These data provide a national perspective on substance use, mental health, and treatment needs in AIAN communities. And after today's meeting, the slides will be available to you, so you'll be able to click the link to view the full report. Over 1/3 of AIAN people aged 12 or older used an illicit drug in the past year, with marijuana being the most common, and other drugs like prescription pain relievers and methamphetamine were also reported, but at a much lower rate. And we'll take a closer look at how this breaks down by age group. Drug use is most common among AIAN adults aged 26 or older, where about 41% use illicit drugs and 34% use marijuana in the past year. And young people aged 12 to 17 reported much lower rates. And while these numbers reflect use, we also want to understand how many people may have developed a substance use disorder. About 1 in 4 AIAN people has substance use disorder in the past year, most often related to marijuana, alcohol, or other drugs. This shows that while many may try substances, a significant number also experience serious challenges with substance use. And we also want to compare this to other racial and ethnic groups across the US. AIAN people had the highest rate of substance use disorder compared to other groups, at 25%, which is higher than multiracial, white, Black, and Hispanic groups. And even though many AIAN people experience SUD, let's now look at how many actually seek treatment or feel that they need it. So this represents the perceived need for substance use treatment. So nearly all AIAN people with a substance use disorder who didn't get treatment said that they didn't think that they needed it. Only a small number sought help or felt treatment was needed. And along with substance use, mental health is also another factor to consider. So let's see how often these challenges all happen together. So over 1 in 10 AIAN adults had both a substance use disorder and a mental illness, and overall, more than 450,000 AIN adults had either one or both conditions. So these numbers highlight the need for integrated services that addresses both mental health and substance use to better support AIN communities. Next, I'll be going over our local county data and our drug overdose trends. San Diego's drug overdose death rate nearly doubled from 2019 to 2023, but saw a significant decline in the most recent year, dropping to 28.1 per 100,000 residents. While rates remain elevated, you can see that they're still below the state and national averages. Because the number of overdose deaths among AIN residents are relatively small each year, we combined 5 years of data to get a more stable and reliable rate. This is important because when numbers are low, the data can jump around a lot year to year and may not show the full picture. So by combining the data, we can understand longer-term patterns. The pooled overdose death rates for American Indian Alaska Native residents in San Diego County was 58.4 per 100,000 from 2019 to 2023, higher than all other race and ethnicity groups. And here's a map of our 5-year pooled total drug overdose death rates, just to keep in mind that this is for all San Diego County residents and not just AIN population. So you can see the highest overdose death rates are concentrated in Central San Diego, Palma, Paloma Julian, and Mountain Empire. So to better understand the potential behavioral needs among the AIN community in San Diego, we applied the national prevalence estimates to our local population of almost 100,000 AIN residents. And this estimate comes from the American Community Survey. And based on this, approximately over 20,000 AIN may have experienced substance use challenges in the past year. However, we recognize that these figures are not perfect. They reflect national trends, not local realities. So our intention is not to stereotype, but to begin conversations around access to culturally grounded and community-driven support. And we welcome your input and stories to help shape a more accurate and respectful understanding. And as we just discussed, national data show that many individuals experience both substance use and mental health challenges, what we call co-occurring conditions. And to explore how this might look locally, we apply those same national rates to San Diego County's AIN population. And based on these national estimates, we expect that over 10,000 AIN residents in San Diego County may be living with both a substance use disorder and a mental illness. And that's nearly 1 in 9 adults in this population. Just a powerful reminder that co-occurring challenges are not uncommon and that we need systems of care that don't treat mental health and substance use separately. Next, I'll be going over ED encounters in San Diego County. So these are from emergency departments that are civilian departments, so we don't have any data from the VA hospitals. The encounters are combined of discharges and hospitalizations, and we'll be looking at any mention of opioid-related and amphetamine-related ED encounters. In 2023, AIN residents had the second highest rate of non-fatal substance-related emergency department of ED encounters at 3,398.6 per 100,000 residents, surpassed only by the non-Hispanic Black residents. And this underscores the disproportionate burden of substance-related health issues. AIN rates increased by 18% from 2022 to 2023 for opioid-related medical encounters. And in 4 of the last 5 years, AIN had the highest or second highest opioid-related ED rates. And this trend just highlights the need for focused prevention and response efforts in the Native communities. So when we look at the amphetamine-related medical encounters, in 2023, AIN residents had the second highest rate of amphetamine-related emergency department visits, with 942 encounters per 100,000 people. And this rate has increased by 90% since 2021. So far, we've been looking at the emergency department encounters, which show when people come to contact with the healthcare system for immediate needs. It's also important to step back and examine substance use patterns earlier in life, especially among the youth. So this slide shows findings from the California Healthy Kids Survey focusing on American Indian and Alaska Native youth in San Diego over the last decade. So across all grade levels, self-reported alcohol and other drug use in the past month has steadily declined. For example, in 2013 to 2015, nearly half of 11th graders reported use, 46%. And by 2021 to 2023, that number has dropped to just 14% and a reduction of 32 percentage points. We also see decreases among younger grades. Ninth graders drop from 23% to 12%, and seventh graders drop from 10% to just 4%. And now we'll look at how AIA and youth substance use compares to all youth in the county. So AIAN and San Diego youth reported similar alcohol and drug use in seventh grade, but by ninth grade, AIAN youth reported higher use at 12% compared to the 9% for San Diego youth. And by 11th grade, use is similar again, with 14% of AIAN youth and 16% of San Diego youth reporting alcohol or drug use in the past month. I'll wrap up this presentation with a few key takeaways just that highlight the most important points. And so AIAN communities in San Diego County face a disproportionate impact of substance use disorders consistent with national trends. Co-occurrence of substance use disorder and any mental illness highlights the importance of integrated behavioral health services. And reported substance use has declined across all grade levels for AIAN youth. And remembering that statistics are only a starting point, understanding AIAN behavioral health needs requires ongoing community conversations to reflect lived experience, cultural context, and self-identified priorities. And the next slides will highlight some of the county's initiatives along with the data reports that you can access. So across the county, there are several initiatives and reports focused on substance use and behavioral health. So here at the SUOPT, we recently released the annual report card. The Binge and Underage Drinking Initiative also published its latest data report. And the Cannabis Public Health Initiative offers a variety of resources, including a newly released comprehensive data brief on cannabis. So our overdose surveillance and response program, OSAR, also recently launched a drug overdose data dashboard, and our community health statistics unit publishes a 5-year report on tribal communities in San Diego County, with the most recent report released this past July. So this report provides a comprehensive look at health and well-being outcomes among the AIAN population. And San Diego Suicide Prevention Council also does important work in suicide prevention and resources, and their updated annual report will also be coming out soon. And of course, this is just a sample of the many initiatives and reports led by different county departments and partner organizations represented here today. And together, these efforts just highlight our shared commitment to improving the health and well-being of our neighbors and communities. And here are some additional resources for anyone needing assistance with mental health and substance use care. And here are the data sources for the information presented today. And this is my contact information. Thank you for all your time today. The slides will be shared with you after the meeting, and please don't hesitate to email me with any questions or feedback. Thank you so much.
So today we're going to be presenting on substance use prevention and Native Americans in San Diego. It'll be myself and Richard Garcia. A little bit about us. I am the Substance Abuse Prevention, Treatment, and Aftercare Project Manager here at the San Diego American Indian Health Center, and Richard Garcia is our Substance Abuse Psychotherapist and our Wellbriety Facilitator. He will hopefully be joining us later in the presentation to go over Wellbriety. And I just wanted to share a little bit about the San Diego American Indian Health Center. If you are not familiar with it, we are located centrally in San Diego. We were founded in 1979. But as I was saying, we are also an Indian Health Services funded nonprofit organization. We provide medical, dental, and behavioral health services, as well as a broad an encompassment of community wellness services for all people of San Diego, and our patient population consists of about 32% Native Americans as of right now. All right, and a little bit of context, I wanted to thank Sandy. She gave a great background on the urban Native American population and Native American and Alaska Native population in San Diego. So I'll just cover this quickly since I know that we already got this background and context. But for the urban Native population, about 70% of American Indians and Alaska Natives live in urban areas in the United States. So that's off tribal land. And there's also higher substance use prevalence. American Indian and Alaska Native adults have the highest prevalence of both illicit drug use and substance use disorder compared to all adults. Barriers in urban settings include limited access to culturally grounded prevention and recovery services and fewer connections to traditional community supports, which results in an impact of elevated risks for addiction, mental health challenges, and intergenerational trauma compared to general US population. And here's just a graph showing this. So this is from the National Survey on Drug Use and Health from 2021. This is the prevalence. It's a representation of what I just shared in the last slide. So about 36.1% of American Indian and Alaska Natives from this data were using illicit drugs, and 27.5% of them presented with substance use disorders. And it's a little bit higher compared to multiracial and to other ethnic groups. Just some context of historical trauma and cultural displacement. This is really important in understanding substance use disorders among today's American Alaska and American Indian populations. So there's been cumulative emotional and psychological wounds that have been passed down through generations. This has been rooted in colonization, genocide, forced relocation, and cultural suppression. Examples of this is Trails of Tears, where American Indian and Alaska Native populations were forcefully moved from their native lands and moved into other areas. There was also boarding school abuses, outlawing of Native practices, and this has really created a lasting impact. This is trauma that's been carried intergenerationally. It affects families, communities, not just individuals. And there's an ongoing disconnection from land, cultural, and traditions, which weakens resilience, especially among the urban Native populations, which are not connected to their tribal land or not on their tribal lands, and maybe not as connected with their culture. So this creates gaps in protective factors that sustain community well-being. And this directly ties to addiction. So, historical trauma increases vulnerability to addiction and mental health disorders. To the right, there's a figure on the cycle of historical trauma, which I thought was a good visual to include. So, there's the history of trauma and historical trauma, which leads to traumatic stress reactions, including grief and other strong emotional and physical reactions, therefore leading to increased risk of substance abuse and dependence, increased vulnerability of suicidality and mental disorders, and therefore increased risk of experiencing other traumas, including examples are accidents, violence, physical and sexual abuse, and it's just a cycle that continues intergenerationally as well. So substance use can emerge as coping with unresolved grief, stress, and loss, and there's a higher risk in communities impacted by cultural erasure and displacement. So there's some barriers to treatment, especially with urban Native populations. Many Native individuals may struggle to access culturally appropriate addiction services, and a common obstacle includes the lack of transportation, limited knowledge of available services, and stigma around mental health. So this is something that Sandy went over, but just to cover it again, Native communities in San Diego experience higher rates of behavioral health issues, including substance abuse, and that is from the San Diego County Tribal Brief from 2023. And urban settings can increase isolation and weaken connection to tribal identity, and that loss of cultural identity reduces protective factors against addiction. So when it comes to prevention, specifically with Native youth, Research has found that peer-led, culturally grounded programs show strongest outcomes, and this is within the urban Native youth population, just to clarify. School-based interventions as well, including combining education, skill building, and ongoing support, reduce or delay substance use, and cultural identity is a protective factor, which strengthens resilience and lowers substance use and depression. So this is something that the San Diego American Indian Health Center focuses a lot on, is prevention among youth. So we have a lot of different peer-led programs, a youth center that provides cultural activities such as moccasin making, beading, and even a therapist that is included in those different activities. So that for Native youth. As for prevention with Native adults and families, it is similar. So, family and community involvement does support healthy decision making and long term outcomes, as well as culturally grounded prevention models will improve engagement and recovery success. So, one of those I will go over in the next few slides. It's our Wellbriety talking circles, and that is something that was developed for Native American individuals that were struggling with addiction. Another one is intergenerational healing, which is strengthening cultural connections, which reduces risk across the lifespan. So, involving Native families, adults, children in these cultural practices really reduces and overall prevents substance use disorder. All right. And I don't believe my co-presenter was able to get into the Zoom. So these were the slides he was going to cover. He is our Wellbriety facilitator, but I will just go ahead and talk about this. So healing through culture, Wellbriety movement. Wellbriety is sobriety and wellness together. It's healing through the mind, body, and spirit through cultural values. That is something that we see a lot in our programming, which is encompassing the mind, body, and spirit. And this was through one man's vision, which helped transform recovery for Native communities across the country. So his name was Don Quiz. He is Mohican from Wisconsin. He founded White Bison and he did so to support Native recovery. He was in a corporate career and he dedicated his life to healing and being sober since 1978. They still teach this class. They have Wellbriety, 12 steps to healing. And the Wellbriety vision really was born during a spiritual fast that he had in Colorado, which was inspired by a vision of a white bison. Therefore, it's called White Bison. So here we have our Wellbriety program talking circle. We approach this through culturally sensitive recovery. So these Wellbriety talking circles are held at our health center in Bankers Hill twice a week. And this is really for recovery from addiction and alcoholism. It reconnects individuals with traditional practices and community support. It is open to all individuals. You don't have to be Native American, but it really does encompass the traditional practices of for Native healing. And a bit about our specific prevention programs for Natives, which really supports resiliency and prevention. We have 3 different main programs that are focused on prevention in youth. We do have other programming that is culturally sensitive and focused in different areas such as diabetes prevention, suicide prevention, but I wanted to highlight these 3 today. So first is SAPTA. That's the Substance Abuse Prevention, Treatment, and Aftercare program, which I'm the project manager for. With this, we aim to reduce substance use among American Indian and Alaska Native youth and adults by expanding culturally grounded care, early intervention, and Generation Indigenous initiative. This includes expanding our behavioral health services. We have a case manager that help, does intake, referrals, and we expanded that service. And we also expanded Generation Indigenous Initiative, which includes raising a tribal youth council, working with schools on prevention, and hosting workshops. With Native Connections, similarly, it's to prevent suicide and substance misuse, address trauma, and promote mental health among urban American Indian and Alaska Native youth. We host a GONA yearly with that program and also have a tribal youth council. As mentioned previously, with prevention, it is important to have the youth involved and peer led. So that is something that we do focus on with our councils and leadership. Additionally, we have the Prevention and Early Intervention or PEI program, which promotes wellness and mental health for urban American Indian and Alaska Native youth by increasing cultural involvement, community participation, and access to culturally grounded services. This is through our youth center, which is also in partnership with the San Diego School District. And as I mentioned previously, they host different activities. It could be moccasin making, beading. They have family nights with our nutritionist that cooks a Native American meal. So those are just some examples of the prevention programs that we have and how we promote resiliency and prevention in the Native American and Alaska Native community of San Diego. And that is all I have for you all today. Unfortunately, Richard couldn't join, but his contact information is there. He's our Wellbriety facilitator again, so he has a lot more information and so much that he could share about our Wellbriety talking circles. There's a lot of knowledge there, and it's a really, really great service.
Good morning, everyone. Thank you for having us, and thank you for your attention. Today, Summer and I will be discussing SD Relay, a relatively new program launched by BHS. For those of you who I haven't met, I am the Deputy Chief Population Health Officer at Behavioral Health Services, and I'm joined by Summer Rahe, Clinical Supervisor for Strive Government Services. So with that, I'll get started. Next slide. So Relay is a 24/7 behavioral health peer support response system delivered by peer specialists in selected emergency departments in San Diego. And those include Scripps Mercy Hospital San Diego, Scripps Mercy Chula Vista, and UCSD Alvarado East Campus Medical Center. SD Relay is modeled after a similar successful program in New York City called NYC Relay. And Relay has two main components. One is an initial ED interaction, and then the second is a 90-day period of continued peer navigation and support. So in this model, the program dispatches a peer support specialist to engage the patient, provide harm reduction resources and non-clinical support to connect them to community resources and meet their most pressing needs. The goal is really to help bridge the gap between hospital discharge and community support. We officially launched in February, and to date, we've had over 100 referrals, many of whom are actively engaged in the program. Next slide, please. So Relay is for patients who have experienced a non-fatal overdose or present with an involuntary behavioral health hold. The program supports care transitions for individuals 18 years and older from the emergency department via peer-led warm handoffs to vital services, including harm reduction, behavioral health, and recovery and community support services. And I should also say that this serves Medi-Cal insured and Medi-Cal eligible patients. Next slide, and I will hand things off to Summer.
Thank you, Dr. Kattan. So a little bit about our approach. We provide 90 days of peer support, and we use a three-phased approach. I'll talk a little bit more about that in a bit, but all of our peer support specialists are certified individuals with lived experience of mental health or substance use challenges, and they really work to leverage their own lived experience to help empower our participants on their own recovery journey, whatever that journey might look like. Our program is really rooted in harm reduction. So we provide things like Narcan and fentanyl test strips, and also connection to harm reduction resources. And we're also really rooted in trauma-informed care and pride ourselves on in implementing trauma-informed care and trauma-informed care principles, like strong rapport and mutual collaboration. And our program is guided through the critical time intervention model. So that's kind of where those 3 phases come into play. Ultimately, our aim is to provide immediate and ongoing support across that 90-day time frame to help provide some stability after that kind of crisis point in the emergency room, and to help promote continuity of care after discharge. Next slide, please. So this kind of shows our referral process a little bit. Essentially, when one of our partner hospitals has a patient presenting in their emergency room for a non-fatal overdose or on an involuntary behavioral health hold, they'll then provide a referral directly to our peer support specialists. They can do so using our referral hotline, or at one of our hospitals, we'll also lobby at the hospital so the staff can come out and provide that referral to us verbally. Once we receive the referral, we verify some patient information and eligibility information, and our peer support specialists will immediately respond to that referral to meet the patient prior to their discharge from the hospital, which then kind of begins our initial engagement. So if we could go to the next slide, please. Thank you. So our initial engagement at the emergency room, our peer support specialists will introduce themselves to the patient. They'll introduce our program and provide some additional information about what we can do for the patient. We'll also get their written consent to participate in the program. And as I mentioned, we're very rooted in harm reduction principles. So during this initial engagement, we will provide the patient with a harm reduction kit. So that includes Narcan, fentanyl test strips. We'll train them on how to properly administer Narcan and how to use fentanyl test strips. And these kits also include additional resources, information on how to contact our support line, which is a phone that's monitored by our peer support specialists on a 24/7 basis. Those kits also include things like emergency blankets, water, snacks, and at this initial engagement, the participant can also obtain a temporary prepaid cell phone. We call them relay cell phones, if they do not have another means of communication. Essentially, the goal for this initial engagement is to begin to build some rapport and really equip the participant with the knowledge, tools, and resources that they need to promote their longer-term safety and hopefully help to prevent any future overdoses. During initial engagement, we also kind of begin the resource connection process here, and try to link them to community resources upon their discharge. So frequently that is inpatient detox, but it could be really whatever they need, shelter, housing, residential treatment. We kind of begin those resource connections at this initial engagement. Next slide, please. So the critical time intervention model is this kind of 3-phase approach that we use. So phase 1 includes that initial engagement at the hospital, and it also includes a post-discharge follow-up where our peer support specialists will reach out to follow up 24 to 48 hours after they've been discharged from the hospital. During that follow-up, we'll check in and kind of see how they're doing, see if they use the resource that we were able to connect them with in the emergency room. We'll conduct a needs assessment and help navigate them to any additional resources they might need. This first phase is 45 days, and throughout those 45 days, our peer support specialists will check in on a weekly basis. We'll work on goal setting and really focus on building up their support network and continue to connect them to whatever kind of resources they might need. And then phase 2 is the following 30 days, and this phase is a really important time for reassessment. So have they been using the resources that they've been connected to? Are those resources helping them meet the goals that they might have set out in phase 1? Or do they need different resources? Essentially just kind of reassessing their strength in connection to resources and trying to facilitate some self-sufficiency in navigating community support. Resource linkage during phase 2 might expand a little bit more. So whereas phase 1 might have focused more on treatment facilities, now we might be focusing a little bit more on things like transportation or housing, or even employment services. Ultimately, it's kind of case by case though. And then phase 3 is the final 15 days of their 90 days of peer support. And by this point, our peer support specialists are kind of starting to take a step back. And we really just want to ensure that our participant feels well connected to the resources that they've been linked to, and that they are kind of self-sufficient in navigating resources for whatever they might need. Ultimately, this approach is shown to help prevent relapse and or readmission to the hospital. And just for a little additional context, we have received 135 referrals to date. Of those, 122 were engaged with at the hospital, and 100 have enrolled in Relay, meaning they accepted services and began their 90-day period of peer navigation and support. And we're already seeing some early successes with many of our participants completing their 90 days. Some of them are now sober and actively engaged in NA. Others are in residential treatment facilities, and all of them that we've maintained contact with have shared positive feedback about the resources they were connected to and their experience with our peer support specialists. So we're really excited to continue this program and to continue to grow. Next slide, please. So this is just our contact information. If anybody would like to reach out for additional information, please feel free.
OSAR dashboard went live. We hope that it's used broadly in the community, and for different purposes, for health providers, for public health practitioners, for law enforcement, really, a broad group of stakeholders, and hopefully is useful to provide real-time data, or near real-time data. So today, I had a late breaker that I just wanted to share, and it is a project that the San Diego County Public Health Lab has been involved with since January. And the project is called the Wastewater Drug Detection Project on the U.S. Southwest border. This is a pilot project that's funded by ONDCP. The pilot project does end this month. However, we just got access to the data, and I don't have a comprehensive look at it, but I just wanted to kind of introduce this, and at the next meeting, I'm happy to go into more detail. So the project collects wastewater samples from 3 different facilities in San Diego, Point Loma, South Bay, and Escondido. And the target drugs are really broad. So, a broad group of opioid compounds, amphetamines, other drugs, and treatment drugs. So, here we're seeing, in the opioids, we're seeing nitazines, so some novel substances. In the other, we're seeing xylazine, and so really kind of a broad scope of drugs that are being tested for. Here's just an example of the graphs that are on this data set. So these are methadone concentrations that we're seeing at different wastewater sites in San Diego, and seeing kind of the trends in them. Sorry, I think my slides are out of order. So, I think sorry, let me get back here. Yeah, in terms of the value, I think it can help guide, treatment drug distribution plans, with, if you're seeing low buprenorphine concentrations in areas that have high opioid use rates, that can help, target promotion of bup in a particular area. If you're seeing, when you have longer term trends in drug concentrations, And then you're seeing an increase that can help facilitate spikes in certain areas. And then for novel substances like nitazines or xylazine, that can help identify earlier than drug testing or crime lab testing, that can help identify trends more upstream, and can really help providers in the clinical settings. So, I think those are just that's just some of the value that I think wastewater drug testing can provide. Again, I can go into more detail at a future meeting, but in terms of the next steps on this, because again, this is a pilot project that is ending this month. The good news is that San Diego County Public Health does have the capacity to test for drugs in wastewater. So they recently procured a mass spectrometer, and they will start wastewater testing for infectious diseases next year. So we have the capacity to add on drugs along with infectious disease testing, but really the ability to test drugs and really the scope of how many drugs we can test at the public health lab is likely going to be a funding question. So that is something that I'll be working on. A lot of people at the county will be working on to try to secure sustainable funding for what I think is an important piece of drug epidemiology here in the county.